Thank you. We are running short of time, so I'll be in hurry. But I have few cases that are managed outside the cath lab. The complication managed mostly outside the cath lab, and some thought-provoking features in my cases. My first case, that drama beyond a successful intervention. The patient is a 40 years old, non-diabetic, normotensive, non-smoker male, chest discomfort and palpitation for 6 hours. He had a vaccination of third dose of COVID vaccine, Moderna vaccine. The first two was the AstraZeneca, 6 hours before. Troponin I was raised. Echocardiography, there is a wall motion abnormality, and this is the admission ECG. So some STT changes, but few PVC is there. And the PVC is continuing on the next morning. The patient admitted on the night, couplet, and we tried with amiodarone bolus, no response. Electrolytes were normal. Planned for early invasive strategy. And this is the angiography. The culprit probably the OM1, LCX also a minor disease, and LAD proximal also significant disease. So we stented the patient, first the OM and then the LAD, straightforward, and the patient was doing well, nothing. But during the procedure, the PVC is also continuing, occasional PVC. So the patient is doing well in the CCU. On the next day, he was shifted to the step down. This is after PCI. ECG is still PVC is there. PVC is continuing. And on the next day, for 24 hours after the PCI, the patient developed cardiac arrest. The monitor showed VT, immediate resuscitation done with DC cardioversion. Electrolytes were normal, and I was not there. The Professor Mir Jamaluddin sir was there, and I asked sir to check the angiograph whether we any occlusion of any vessel. This is post resuscitation ECG, and this is the angiography. The stents are fine. There is no lesion in the stent. So what might be the cause? And this is the echocardiography. My mysterious explanation is, could it be a vaccine-induced arrhythmia? There are several papers. These papers are of more than 1 crore patient with vaccine studied in UK, and they are studied both AstraZeneca, Pfizer, and Moderna vaccine. And out of that, 1% of patients admitted in hospital or with or died from cardiac arrhythmia, and there are 7,750 deaths of cardiac arrhythmia recorded. And they showed that there is an increased risk of cardiac arrhythmia following second dose of Moderna vaccine. My patient was giving the first 2 doses AstraZeneca, the third dose was Moderna, and in the other cases, AstraZeneca and Pfizer vaccine has reduced risk of arrhythmia. So that might be a case of vaccine-induced arrhythmia. The study results showed that the arrhythmia was atrial fibrillation, AV block, ventricular tachycardia, ventricular fibrillation, and SVT. My second case, when a bradyarrhythmia is a nightmare. Here, the tachyarrhythmia was my nightmare. A 45 years old male, non-diabetic, smoker, severe chest pain for 2 hours, developed cardiac arrest within 5 minutes of CCU admission, reverted to DC cardioversion, monitor showed VT, and this is the emergency admission ECG. And when he entered the CCU, he developed cardiac arrest. Emergency resuscitation done, tenecteplase was given, the patient was hemodynamically stable, occasional chest pain, there is regional wall motion abnormality, and this is after the tenecteplase. There is not evidence of successful thrombolysis is not. After 6 hours and pharmacoinvasive strategy, we check the angiogram. There is a dilatation of the right coronary artery, ectatic dilatation, and the proximal LAD has 70-80% stenosis. We straightforward stented the patient. If we carefully look the septal branches, because that will factor in later on, there is a septal branches, a small septal branches is occluded 99% in the angiogram. So we stented the patient straightforward, and this is the post-PCI ECG. On the next morning, the patient's ECG started to change. The right bundle branch block developed, and there is on the next day, the monitor showed that the complete heart block. We retrieved this ECG from the monitor, and the patient has no chest pain, but there is a slight reduction of blood pressure, 90/60. And we are in puzzle what to do. And this is after atropine. And we started iptifibatide, and after 4 hours of the iptifibatide, the ECG normalizes. So my mysterious explanation is that the occlusion of septal branch of LED may, by thrombus that may produce that may resolve by integralin, and we know that the septal branch supply the His bundle. My third case is the migration. This is not bird migration, this is migration of a stent. 45 years old male, hypertension, diabetic, non-STEMI 2 weeks back, CAG done in other city, and this is the lesion, straightforward lesion, PCI done with all precaution, 3.5 millimeter stent, with 28 millimeter was given, and post-dilatation. After 2 months, the presented with severe chest pain, ECG non-specific changes, troponins were marginally raised, check CAG done. This is the ECG on second admission. Look at that. If we, the view is not so good, the stent is outside the flow of the RCA, and the distal vessel is almost totally occluded. So for clear view, the red mark is the stent's site. So how it can be occurred? That there is a new path of blood, and there is a distal flow is. So there are many questions, and so aggressive disease progression within 2 months. Can it be a hypersensitivity reaction to the stents? My mysterious explanation was an aneurysmal formation at the site of the stent, implantation followed by stent thrombosis. The remaining flow is outside the stent through the aneurysm. The cause might be hypersensitivity, most likely, and mycotic aneurysm may be another, but it is less likely that the patient has no fever after the procedure. And we have done the CT angiography. The stent is well visualized, and this is the CT angiography. The stent is outside the aneurysm, and there is no flow across the stent, and so this is the stent migration. And my fourth case, anaconda in the coronaries. This is the case of 55 years old female, diabetic, shortness of breath, chest discomfort on minimal exertion for prolonged period of time. ECG, I will show that. Echocardiogram, there is the anterior wall hypokinesia, and ejection fraction is 40%. So there is the all anteroseptal MI, incomplete LVBB, LVH with strain, all thing here. So this is the coronary angiography. We can only cannulate the LCX. We cannot cannulate the LED. LCX is aneurysmal, and there is a flow, retrograde flow to another chamber, like dilatation. There is a, we first thought that that is the coronary cameral fistula, but this is the LCX, another view, and the larger channels is there. And from LCX, the catheter dislodged to the RCA, and the RCA is anaconda. So this anaconda is filling the distal part of the LED, probably. The distal part, the view was not so, because we are using the 5 French catheter for transradial approach. So the visualization is not so good, but there is some visualization of LED. So is LED is totally occluded? We first thought that. So my mysterious explanation is extremely aneurysmal dilatation of RCA and LCX. LED may be totally occluded, retrograde filling of part of the LED, and seems to be a coronary cameral fistula. But we have done the CT coronary angiogram. Look at that, the RCA and LCX arising from the LED, and RCA and LCX arising from the aorta, but LED arising from the pulmonary artery. This is the pulmonary artery origin, the front one. This is the LED origin, and the behind the LCX and RCA origin. This is LED from pulmonary artery, and this is the LED origin from pulmonary artery. This is the RCA origin from aorta. So this is an adult Al Kappa. Is it very, very rare case? Very, very rare. This is the origin of LED from pulmonary artery. We retrogradely checked the echocardiography. We found then flow acceleration in the pulmonary artery. This is the flow acceleration. So there is a coronary steal syndrome. When there is the pressure in the pulmonary artery is low, blood steal from the heart to the pulmonary artery. So for that reason, there is the pulmonary artery flow acceleration. And we can also recognize that hugely dilated right coronary artery orifice from the aorta. So there is no left coronary artery orifice from the aorta. So this is my first case, and my mentor, Professor Mir Jamal, was present, was there. He never seen in his life of intervention of long life. So adult L-kappa in adult is extremely rare. True incidence in adult is not known. It is estimated that 1 in 300 live births. Most of the patient died within first year of life. Symptoms usually arise within 2 to 3 months. Survival into adult life without surgery is possible, and there are few case reports in the literature. Thank you. Thank you for your patience hearing. This is my cath lab.